This is the 21st of April, 1976, Denver, Colorado. This is Gerald Rayner, and I have the very pleasant opportunity to talk with Dr. Gerald Brom from Leiden, Netherlands. Dr. Brom is passing through Denver for a day or two, visiting with Henry Swan and Dr. Sadler and myself on his way to the American Association for Thoracic Surgery meeting in Los Angeles. He has spent the last 2 days with Dr. John Kirkland and his group in Birmingham. I've asked Dr. Brom to simply reflect in a most informal way some of his thoughts and experiences in the early days of cardiac surgery in his area of the world. And I hope that in so doing he will give us the events of the period that led him to do some of the earliest cardiac surgery in Europe, along with some of his distinguished colleagues. Dr. Brom.
Yes, my interest in cardiac surgery came along when, because in the clinic where I was working for general surgery, we did a rather good number of lung resections at that time, and I thought that doing lung resections we should get interested too in the field of cardiac surgery, even if we didn't know anything about if it was worthwhile. So I still remember the very day that I really started to be interested. That was in September 47 in London. There was a meeting there, I believe, for internal medicine, and they had invited Blaylock to give a speech about blue babies and the results of his operation for that. And during his speech, some of the patients operated upon at Guy's Hospital were shown. I was present at that meeting with the man who was doing the internal medicine in our hospital, Dr. van Nieuwenhuizen. And that very evening we walked through Regent Park after dinner, and we said we have to start cardiac surgery in our country. But I said I don't believe it is all right to do this without any previous training. So the only way to get training was to go to Crawford in Sweden, who was the only one at that moment in Europe who really did cardiac surgery, because it was Brock who started to do it after the visit of Blaylock. So next day I spoke with Clarence Crawford, and he was willing to accept me in January of that year, of the next year, as an assistant in his clinic. I stayed with him for 6 months, and the cardiac surgery I saw were coarctations. The first coarctation I saw was the 9th of Crawford, and Blaylocks and ductuses. That was the only thing done. When I left Crawford to go home, I took with me catheters to do heart catheterization, because we didn't have that in Holland. I took with me syringes where we could do angiograms through the catheters, and that's how we started in Utrecht in our hospital with doing catheterizations. I did it myself because the internal medicine man didn't dare to do it. I did the angios myself, and that was in a very special way, I have to tell you, because we did it always with two. One had a board of wood in front of his chest and holding the syringe, and the other one was hanging around him and holding the syringe, and then pressing together and pressing the syringe as soon as possible, but always give you a little bit of dyspnoic if you were the one who held the syringe against his chest. And in that way we did our first investigations. It was quite interesting, and but also interesting was that the direction of the hospital thought that it was experimental work on human beings, so I got a official letter, we call it a letter what you have to accept, that it was forever forbidden to do heart catheterization or angiograms in their hospital. This letter was never withdrawn, and you should know now that in this hospital is the largest cardiac center of our country. So I always tell them that they are doing something what's absolutely forbidden by the administration 30 years ago. That is really some of the things what I should tell about how we start in our country. At the same time, I start to work with young blood who had developed a very nice heart-lung machine. The idea about it was a film, a blood film, but was circulating on the surface of a spiral, what was going around. And we did dog's experiment with that. I still believe that it is a very good machine. It never had any clinical results, but that has nothing to do with the development itself. And
Dr. Brom, once you had that developed and you got on into doing first closed cardiac procedures, what led you to doing open heart procedures, say with hypothermia?
It is that we started surely with coarctations, Blaylocks, and those operations, but then we got the message that the work of Bigelow, Lewis, and Swan, and as I knew Bigelow and Swan already from some meetings and who became good friends of mine, I knew about her work, and a few months after Swan did his first operation, we did the first hypothermia in our country in the same way with a bath tube and ice around it and things like that.
This was an atrial septal defect?
Atrial septal defect.
How old was the patient, you recall?
I don't recall.
Did he survive?
Yes, the patient survived, and we did, I must say that our results of atrial septal defects with hypothermia were extremely good.
Now, how did you feel when you did your first one? When you know, this must have been a very exciting moment indeed.
It was very, very exciting because you had a feeling that you was something doing what was experimental, even if you knew that in the United States they had good success with it. There you were standing alone with, let's say, all your critics of the whole country blowing in your neck, and being rather young at that time. I must say that I felt very, very nervous.
When you did your first few straightforward, quote, straightforward atrial septal defects, did you ever wonder just before you opened the right atrial wall that you may find something different?
I always palpated.
Uh-huh.
And
did you ever palpate and find something different and then close if you felt that it was a lesion that you had not anticipated?
At that time, I still remember that I don't know how much, but perhaps it was the 5th or the 10th patient, we found a primum defect. And I opened it up and I tried to close it and the patient died. Mm-hmm. That I remember. Mm-hmm. But after that, we knew how it felt like, and we never reopened it. One who we felt it was a primum defect. Mm-hmm. But we didn't know how to differentiate at that time between primum and secundum defect.
Now, don't you think that during this particular time period that innovativeness came along out of necessity many times? Might you find an anomalous pulmonary vein that you would figure out some way to handle,
yeah,
or to treat with, so that you really had to do something on the spot that you may not have seen or heard of being done before?
Yes, but if you palpated carefully, as we always did, then we took time off before we start to do the operation. Mostly that meant that we went out of the operating room, had a cup of coffee, discussed it over, and then said what we were going to do. We just said, now, before we open that heart, we must absolutely know how to handle it. And I still remember the one case where we found that there was a big valve in front of the inferior caval vein. And we said, when we close this defect, we have the inferior caval vein down on the left side. Not realizing that the valve had nothing to do with the ASD itself, as we know now. And then we decided that we should go around the wall of the left auricle, as was described later on by Lewis. Mm-hmm. I believe Lewis did it before us, but the description came a few weeks or months after that we did it. So we came to the same conclusion as Lewis did and took the atrial wall around, and that cured the patient. But it took us about an hour discussion with coffee.
Just before we began the formal part of this interview, you were telling me about some of the personalities and the driving forces involved. Would you feel comfortable about telling us, and by us I mean the future, sure. What did you see in the people who were pushing ahead in this era that kept them going?
Now, first of all, I think there were two types of people. You had the rather scientific type, like a man like Clarence Crawford, who absolutely was for me a genius in grasping very good ideas, like heparin, for instance. He grasped it. The moment Job was found it, he said, there's something in it what we can use. Crawford had ideas. Now, I must say that Crawford, as a technician, was not such a brilliant surgeon. I may say so. It's nothing against Crawford as a personality, but he was a driving force, and he drove his younger people to the extremes to find something new, what he had really the ideas of. Let's say the Björk machine, who later became known as the K-Cross extrapolar circulation machinery, oxygenator, but in reality it was developed by Björk after an idea of Crawford. And then because that didn't give enough oxygenation because the blood level was too low. The only thing that K-Cross changed in the whole machine was bringing the blood level higher. Therefore, he drove Senning to develop the Senning machine with the drums, who had a very nice oxygenator. So I think you have two different types. And then you have the type of men who just grasp the ideas, have a kind of a feeling for technology, and develop techniques themselves. You see, like people like Swan and let's say Potts. Not that I don't believe Potts had also very good ideas, but he was technically the man who did it. And the same with Bailey, for instance. He was a technical man. And then another thing was, I think, the whole group of people who started that time were young. They were nearly all of the same age. You had a group who was about 10 years older, but the main group was about between 30 and 35 years of age. And
Did you sense in that group a compelling desire to be number one or first about other things they did besides their surgery?
I must say that if you look at the hypothermia group, as I call them, that's the one with Swan, Bigelow, and Senning. They were also competing in a quite different field, and that was dancing. And they, all three, and I want to include myself too, but I'm not on the same class of dancer as the other ones, but I enjoy dancing too. But there was really a high competition between them. And even so, as I just told you the story that Henry Swan, after one of his accidents with a plane, came into the nightclub in Brussels where Oka Setting was just giving a show away of how to dance, and he looked around and he was just out of the cast plaster, and he picked up a girl and he started to compete with Setting in the dancing. The end result was an edema that his leg was about three sizes too much, 3 times bigger. And I must say, by far, Setting was the best. And Swan was a good second one, and then Bigelow and we came.
This was sort of a reflection of their personality and everything they did, wasn't it?
Yeah.
Dr. Brom, you've mentioned the use of the bathtub and the hypothermia and the closure of atrial septal defects. Before you got into using extracorporeal circulation, did you attempt more complicated repairs such as ventricular septal defects using hypothermia and inflow occlusion?
No, never. We never did that. We did, besides atrial septal defects, we did a few pulmonary stenosis, but I must say that the pulmonary stenosis, when you cool them down, we got more ventricular fibrillation, so we rather very early went over to inflow occlusion and pulmonary valvulotomy at normal term. A method we still do up till this very day.
Is that right?
We still do it without
so that if you had a patient with straightforward isolated pulmonic valvular stenosis, you would still use inflow occlusion and normothermia.
I think it is a marvelous operation.
What is your usual duration of occlusion to do a pulmonic valvulotomy?
1.5 and 2 minutes. It's very easily to do. And I was very pleased that Castaneda in Boston does it too still.
Yes.
I was amazed to see it.
Well, sir, we really appreciate your being willing to talk with us. I personally think that this is absolutely superb because so many of us did not ever get the personal grasp of the development of surgery during this era, and it's only people that, such as you, that could feel in such a way that it's so hard to describe.
Yeah. There's one thing what I really appreciate from that period is that during the 4 years that I was working at the hospital in Utrecht only, all the heart catheterization, all the CD angiograms were made by us, by the surgeon, my friend and me, because the man, the internal medicine man, didn't dare to do it. And so I still have the feeling that if I see catheterization done, I say, now, if you turn the catheter that direction or that direction, you'll get there.
Right. That gives you also a broader perspective of things, doesn't it?
Yeah.
Do you recall the contrast medium that you used in those days? Was it Diodrast or Uricon? At least that's what we call them in
Diodrast. I believe it was Diodrast.
Did you ever recall any problems with the contrast agents then? Did you have more fibrillation? Did you have
No.
any problems that you could ascribe to the agent?
No. We have lost one patient on heart catheterization. I still remember that, a child, is a very severe fellow, and I was so proud that I was in the pulmonary artery that I kept the catheter very long in the pulmonary artery, and he took pressure readings and oxygen saturation, and the oxygen saturation got lower and lower, and we lost the patient by blocking off the pulmonary artery. That's one of an experience that I keep my lifelong memory from. It shouldn't be done, but I'm sorry, that's what I did.
Mm-hmm. Well, that's another aspect that you can appreciate that the surgeons nowadays just have no contact with and can't appreciate.
No.
I must have been one of the last surgeons to do some heart catheterizations myself, coming along as late as I did. We still had a few that did this before it was commonplace for the cardiologist. Thank you very much, sir, and we will look forward to seeing you again.